Great. And it is noon, so we'll get started. Good afternoon, everyone. My name is Olivia Henry from the New England QIN-QIO, and I'll be your moderator for today's Quality Payment Program December webinar. The Quality Innovation Network Quality Improvement Organization works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. Thank you for joining us for today's webinar. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation, and we'll take questions at a specific time in the presentation, and I'll provide you instructions on how you can ask a question over the phone or pose a question in the chat box. So at this time, I'd like to introduce today's speaker, an expert from the New England QIN-QIO, Leila Volinsky. Leila, are you there? Yes. Hi, the floor is all yours. Yes, we can hear you.
Great. Thank you, Olivia, and thank you all for joining us today for the December open call, as Olivia mentioned. I'm just going to quickly go through the agenda for today, just so you have a rough idea of what we'll be covering. Just quick housekeeping, as Olivia mentioned, everyone's on mute. You'll get a warning towards the end that you can unmute yourself if you have questions, and Olivia will help you with that. Following the call, there will be a recording and also a frequently asked questions document made available to all registered attendees. What I'm going to be covering briefly is just an overview of MACRA, just talking about the law, the quality payment program, the MIPS programs, the merit-based incentive payment systems, and alternative payment models, just a brief overview, and then jumping into the final rule and some of the things that were changed with the final rule, and also some of the items that we're hearing here at the New England QIN-QIO from our various providers out in the community, practices, and other experts in the field, just so you're aware of sort of what the common questions and topics are. After that, Jenn, one of my colleagues from the New England QIN-QIO, will be introducing our new and updated MACRA website, so you'll be able to find out where some of the resources are, how you can ask us questions, and she'll go through all of that with you. After that, as I mentioned, there will be questions and open discussion, and then we'll briefly wrap up, and you can contact us if you have any additional questions. So, as I mentioned, MACRA is the Medicare Access and Chip Reauthorization Act. This was passed into law in April 2015. Really, its whole purpose was to repeal the flawed sustainable growth rate formula, which didn't really serve the purpose of curbing Medicare spending as the government had initially hoped it would. The second major piece of this legislation was to make the quality payment program, which forms two pathways that providers can get incentive payments, or in the case of the merit-based incentive payment systems, they can also get a penalty. So, as I mentioned, MIPS is the merit-based incentive payment system that pulls together the PQRX program, Meaningful Use, which is also the Medicare EHR incentive payment system, and value-based modifier. So, in pulling those three programs together, MIPS formed four programs for performance evaluation. Providers are evaluated on quality, which comes directly from PQRX, advancing care information, which are the former meaningful use measures. Cost or resource use comes from the value-based payment modifier, and then there's a new category, which is improvement activities, or also clinical practice improvement activities. And those really look at how you are working with your patients and other providers in the community and improving access, patient engagement, and general quality. I also mentioned that there was a second arm to the quality payment program, that's the alternative payment models. For the most part, these are ACOs, so accountable care organizations. I have a little slide actually quickly with some acronyms that might be helpful. So under APMs, providers take on more than the nominal risk. So they expect both upside, so incentives, and risk for not meeting those quality thresholds in caring for patients. Under this program, providers may earn an additional 5% off of their fee schedule, so there's an incentive there. For the first year of the MIPS program, providers either are considered qualified advanced APM participants or MIPS APM participants. There's much more information on that, which I'm not going to get into in this call, but if you do have questions, please reach out to us, and we're more than happy to work through that with you. So, the final rule, released October 14th of this year, it received, this legislation received more than 3,000 comments from physicians, nurse practitioners, members of the community, legislators, and other healthcare organizations such as the New England Quality Improvement Organization. Based on that information, some substantial changes were made. So, as I mentioned, for 2017, which is the first year of the program, all of the efforts that providers are going to make is considered to be the transitional year. So, the requirements were tweaked so that providers had options to report. So, first, quality was moved from 50% to 60%. That's a substantial increase. Obviously, over half of the MIPS score will be coming from the quality component. There's a great resource which Jenn will talk about a little more in a few minutes. Off of our website, you can link to it, which is the Quality Payment Program website created by CMS. They have a nice tool that they're calling like the shopping cart. You can go in and investigate what sort of quality measures you think you might want to report on, what the requirements are, and what sort of reporting methodology that measure requires. It's important to take into account that reporting method because if you're not reporting through a registry, but it is a registry measure, you might need to pick a different measure. The other element is that it's important to identify either an outcome or high priority measure. These high priority measures include appropriate use, patient safety, efficiency, patient experience, and care coordination. We've all heard of all those different elements being watched very carefully and becoming very important aspects of healthcare as we move into this quality payment model. The second element is the advancing care information category. As I mentioned, this comes right from meaningful use. That makes up 25% of the MIPS score, and that is a 5-measure set. For the most part, all those measures are numerator-denominator measures, so that's looking at providing patient access to a portal, e-prescribing, and then 2 measures related to the summary of care. There's also that carryover measure, which is as patient only, so just yes-no for performing a security risk assessment. That's very important to have appropriate documentation. CMS definitely hits those pretty hard for audits, so be prepared for that. You can also get additional credit for reporting on the additional meaningful use measures, so there's some performance measures. You can also get credit for measures, as I mentioned, in the improvement activities that require EHR utilization, as well as using either clinical data or public health registries. So some states have those, some states don't, but if you're participating, you can get additional credit for that. Interestingly, CMS is offering a hardship exemption. Now, this isn't the same as the hardship exemption that was available for meaningful use in previous years when your EHR couldn't make the requirements, although it does look at the ability for EHRs to meet the necessary requirements. So under this hardship exemption, you can request that CMS move the ACI performance score down to 0 from 25%, and that will cause the other 2 categories, so quality and improvement activities, to be reweighted. Now, how is that going to be reweighted? I don't honestly know, but it could be 10% to one, 15% to another, or the full 25 to one of those. As I mentioned, there is a heavy push to quality, so it might be that whole 25% moves to quality. So be aware of that. The next category is improvement activities. 15% of the MIPS score comes from that. You can choose 1 to 4 activities, either weighted as high or medium. High gets 20 points, medium gets 10. You can get a full score of 40, so depending on how you decide to break those up, you can get full score for 4, medium, 2 highs, or any combination of the 2. Important to know here is that before implementing these activities, be sure to review what's available and review the current workflows in your practice. More than likely, you're already doing many of these activities in some form, and so you can more than likely get credit for them. It's just important to look at what you're already doing and how that aligns with the needs of the program. Second, this is all a 90-day reporting period, so quality, advancing transformation, and improvement activities require at least a 90-day continuous reporting period. If you participate in the QPPI initiative, you can get credit for one high activity, so that's 20 points, so half of your reporting score. If you work with the New England QIN-QIO, you can get credit for several medium activities. So we perform technical assistance in many practices that are having issues with workflow or meeting some of the other quality measure activities. You can get credit for that. We also do population health management with reduction of health disparities and management of chronic conditions. We offer diabetes self-management education. That's one of the activities, as well as work with the Million Hearts Initiative. And then finally, we're adding a community antibiotic stewardship program, and that also gets you one of the activities completed. Another note, if you are a certified and accredited PCMH practice at the time that you start reporting, you will get full credit, so full 40 points. Another note here is that if you work in a multi-practice group that reports up to one PIN, so tax identification number, I don't think I have a slide for this. Sorry, I didn't advance any of my slides. You would get credit, so multiple practices reporting to one PIN would get credit for their participation in PCMH, even if one practice of that, let's say 5-practice PIN is accredited, all of those 4 other practices would get credit. So that's a nice little bonus you would get. Also, if you are in an alternative payment model, so participating in any of the ACOs, you would get full credit for the 40 points. And in future years, as CMS adds additional APMs, either through different models or the other payer APMs, you would get at least half credit for 20 points. As I mentioned, cost is not being accounted for this year, so that's at 0% of the score, but it is important to look at your QRUR reports now to identify current utilization and spending for beneficiary to see where you land and maybe where you might be able to tweak things. So next, we're going to talk quickly about who's eligible for MIPS. So under the final rule, we did tweak some of the requirements. So it used to be $10,000 in annual Medicare Part B claims. Now it's $30,000. So substantially more claims have to be submitted to be included in the program. And also, we went from an and to an or statement. It used to be you had to do at least the $10,000 and have more than 100 Medicare Part B beneficiaries. You need to have both the 30,000 and or the 100 Medicare Part B beneficiaries. If you're in the first year of reporting to CMS, you would be excluded, and then also if you're an APM participant, you would also be excluded, depending on where you fall in that program. We can get into it more. Some of the questions we've heard about who is eligible and what sort of patients are included in the scoring are the place of service. So if you have a hospital-based eligible clinician, this individual would furnish at least 70% of their covered professional services under the place of service of 21, which is inpatient, 22, which is outpatient hospital, or 23, which is emergency department. Additionally, those claims are evaluated from September 1st of 2015 through August 31st of 2016. We had another question about a podiatrist who sees about half of his patients at a nursing home. Those patients are not part of his EHR in the office, and he doesn't track them through his practice, visits the nursing home. Those are place of service 32. And at the moment we're doing additional investigation on this. The documentation is a little unclear as to whether they're included or excluded, but if that's an area that you have interest, please let us know and we'll try to get you an answer on that. The next piece is for providers seeing patients at skilled nursing facilities. For the cost reporting piece, which again for this year is 0%, but good to keep in mind. If you're reporting services billed under CPT codes 99304 to 99308 with the place of service of 31, which is a skilled nursing facility, modifier are excluded from that cost attribution rate. Non-patient facing clinicians, so these would be radiologists, interventional radiologists, patients that see less than 25 patient-facing encounters per year. Really good. Reduced reporting activities. So for improvement activities, for full credit, they only need to pursue 2. So either one high or one medium, or half credit is just for one activity. So slightly reduced there. They do have the same requirements for quality, and then there is talk of moving their advanced care information score down to 0, which would reweight the others. So just important to know for what providers you might be working with and where they fall in the spectrum. As I mentioned, for the different reporting timelines, CMS is allowing for about 5 different timelines. One is you don't participate in the program at all and risk getting the 4% negative payment adjustment. 2 is testing out the program. Again, this is a 90-day reporting period. And all you have to report on is either one quality measure or one improvement activity or the 5 required advancing care information measures. The second is a partial year, so that's at least a 90-day reporting period. That requires 6 quality measures, the 5 ACI measure set, and the 4 improvement activities depending on the weight of the activities they're pursuing. For the third year, which is a 365-day reporting period, it's also the 6 quality measures, the 5 ACI measure set, and 4 improvement activities, again, depending on weight. We've had questions about whether or not we need to inform CMS as to the path you're picking in terms of where you plan on reporting. You don't need to inform them. However, you do need to report no matter what path you pick by March 31st of 2018. That's the final date of attestation. You have options to either report as an individual or as a group. An individual is one NPI under one PIN, so again, that's the tax ID number, and the NPI is the National Provider Identification Number. And then you can choose to report using different methods for each of the performance categories. So if you use a registry for the quality measures, you can report via EHR for the ACI measures. It's however it works best for you. For groups, this is 2 or more NPIs that assign their billing rights to a specific PIN. You report as a group for all of the performance categories, and you may choose again to report using a different method for each of those categories. So if it's again an EHR for the ACI measures, you can do registry for the quality measures. GCs and groups or practices of fewer than 10 providers or reporting via the group reporting option may have different reporting requirements, so it's just important to know sort of how you plan on reporting and what sort of requirements you have. And then finally, this final slide kind of explains it. How do you need to prepare? So start evaluating your workflow, look at what measures you might be reporting on, what sort of requirements there might be for your EHR. Depending on what version of EHR you have, you might have different requirements for the ACI category, so depending on whether it's 2014 or 2015 editions. Work with the QIO if you have different questions as QPPIs are part of that initiative. Determine, again, what quality measures you're planning on reporting, and then start looking at those QR/UR reports. So identify where your cost and utilization is. You might be out of where you need to be in terms of colleagues in the area, and it's a good time to start looking at that as cost of 0 again for the first year. So,
Leila, it's Olivia. I don't mean to interrupt you. It looks like the slides are not advancing on our end. I'm not sure if you are advancing them or not. We're on slide 10 resources now.
Yeah, there's only like 10 anyway, so
okay. No problem. Just wanted to let you know. It looks like they just advanced, though. Thank you. I'm sorry to interrupt.
Sure, no problem. Sorry about that. So again, there's resources. Jenn's going to get into this, but we have a MIPS and APM bootcamp learning toolkit, which includes a readiness assessment, so you can go through your practice and identify maybe where there are gaps and you need to spend some additional time and effort. Also looking at what measures you want to report on. We also have lots of resources in terms of linking out to a great calculator, which again, I'm going to hand it over to Jenn because otherwise I will be taking over her piece. So Jenn, it is all yours.
Perfect. So thanks, Leila, so much. Jen, if you go up to the, as we discussed earlier, the share menu and click on my screen. Perfect. Looks like it's syncing. Okay. And we can see your screen. Thanks, Jen.
Wonderful. Thank you. Thank you for that great information. I'd like to take a few minutes to walk you through a resource that we hope you'll use frequently and encourage your practices to use it. You can see right now that we're on our home page for the healthcarefornewengland.org. There are a wealth of resources. And what I just did is click on the www.healthcarefornewengland.org/initiatives/macra/. And here what you're looking at is our newly launched Making Sense of Macra, the Quality Payment Program. This website is available for you and your practices, and we're looking for feedback about whether or not you find these resources helpful. So feel free to reach out to us and let us know what you think. What I'd like to do is bring your attention to this box in the right-hand corner with the title Recent News. And here is where you'll find calls to action, typically with deadlines attached to them, and you'll see that we've highlighted that there are a couple days left to submit an informal review with a link directly on how to do that, and then there's a link to Physician Compare here. So this information will be changed frequently. Come back and visit this recent news box for updates. On the left-hand side, there's an option to sign up for our newsletter here, and if you prefer to be reminded of important deadlines or updates in your inbox rather than coming to the website periodically, then this is for you. We are sensitive to the frequency of emails, and we do strive to include only the most relevant information. And also, it's a good time to mention that CMS is producing 3 Quality Payment Program webinars that will be distributed by the QIN-QIO nationwide. These webinars are oriented toward basic clinicians. They're coming in at about 20 minutes or less. And the bonus is that clinicians can earn CMEs for participating. So if you would like to receive notice of when the educational modules are available, be sure to sign up for our newsletter and encourage your practices to do the same. Okay, so I'm going to bring your attention now to this first button right here, entitled Webinars and Calls. If you click on that, you'll see a list of all of the webinars and the dates that we have done these webinars. If you click on any webinar here, you'll get a recording, and if there is a slide deck associated with it, you can also find that. Going back to the main web page, if you click on the newsletter button, you'll see a similar list. This is our monthly newsletter oriented toward physician outpatient practices. And you can see it goes back to November of 2015. We have a wealth of information here. It's in a PDF format. So feel free to scan that at your convenience. Okay, next, this is a very popular feature called the Ask the Question. And what I like about this is it allows the user to ask a personalized question and receive a response from a subject matter expert within 72 hours. So this is a great resource that you want to share freely with your practices as they're deciding what and how to report for the QPP. Okay, next going back to the main page, now I'm going to bring you to the second button here. This is entitled Macra Resources. And we're really excited to bring you a variety of resources which will be updated as new information comes in. So Leila mentioned the Quality Payment Program CMS website, and you can link to that just by clicking on that first box. One of the nice features in here is that you can create a personalized list of quality measures and download that in an Excel or CSV format. The next resource here is the executive summary of the final rule. So if you've been scared off reading that 2,000 plus page MACRA final rule, then I would suggest you start here, which comes in at about 24 pages. Now certainly it doesn't go into the depth of the final rule, but it gives you a nice high-level overview. And certainly for those practices who perhaps have been burning their head in the sand, wishing that this would go away, this is a nice place to start. I think it's really palatable. The next resource I want to bring your attention to is something that Leila created. And so if you are starting to think that learning about MACRA is like learning a new language, then you'll appreciate our 2-page acronym cheat sheet here, which has hyperlinked resources next to each topic. Once it gives you the acronym, it gives you what it means, and then that nice hyperlinked resource. Going back to our MACRA resources page, Leila mentioned the MIPS APM date stamp that we created here, and this is a really nice overview of the categories and the assigned percentages. And then on the second page of this is what she mentioned, the readiness assessment. And here is where users will complete this survey, and what it will do is identify gaps that might need to be focused on. And so this could be filled out, for example, and returned to one of us at the QIN-QIO, or perhaps as a facilitator of the QPPI, we could use this to talk about how the practice is preparing for the submission. So going back to our MACRA resources here, now I want to introduce you to a really great tool that was developed by the American Medical Association. You do need to create an account to utilize this resource, but it is free. And what it does is brings you to what's called the Payment Model Evaluator, or PME. It takes about 10 minutes to complete, and it is a logic business tool based on information supplied by the practice about their financial and reporting structure. And at the end, the user receives an assessment summary that recommends the optimum payment model for the practice, whether it be MIPS or a MIPS APM or an APM or an advanced APM. So that's a great resource. The next resource I'd like to bring your attention to here is the Quality Resource and Utilization Report. And we would mention this important confidential feedback report, which is really crucial for practices to obtain. This information that we have here is how to obtain the QIUI. I'm not going to go into the details because everything is here. But if you are working with a practice that has not access to QIUI, I highly encourage you to have them do that. Next, we have the SA Ignite MIPS Financial Calculator. Again, similar to the AMA tool, you will have to create an account. However, this is a free account. And this brings you to a really unique tool that allows practices to determine if they'll be receiving a potential MIPS incentive or penalty while understanding the factors that contribute to the scoring. And like I said, that is produced by SA Ignite, and they're giving us permission to use it here. I also want to bring your attention to what's called Physician Compare. It allows the people with Medicare to make informed healthcare decisions. And we want to encourage your practices to review their data for accuracy and to report any changes to CMS. Our link here brings you directly to the Medicare.gov web page where you can find a wealth of information about Physician Compare. And I suggest that in the future this is going to be used and be developed into a more robust database. So you probably want to put that on your practices later. So that's it for now. Again, once you have the opportunity to peruse our webpage, let us know what you think. Send me an email, send me an email. Let your QIN-QIO let know your feedback is wanted and needed, and we really want to make this webpage helpful. Thanks. Okay, Olivia, do I give the ball back to you now?
Thanks so much, Jen. You can go up to your the share section again, and you can press stop sharing.
Okay, I'm going to do that.
Perfect. All right. Thank you so much. Now it is back to the handouts. I just want to thank Leila and Jen for such a great presentation. If it's okay, Leila, I'm going to open up the floor for questions, unless you had anything else that you'd like to add, or Jen?
No, perfect on my end.
No, thank you, Olivia.
Okay, so if you do have a question that you'd like to ask, you can press #6 to unmute your phone line, or you can pose a question in the chat box. Please just make sure to send to all participants so we do see your question. Again, #6, or you can pose a question in the chat box to all participants. I do know that we have some other staff from the New England QIN-QIO on the line. I didn't know if there was anything else that they would want to add at this point. If not, that's fine. But again, if you would like to add something, #6 to unmute your phone line.
I work here in Vermont. We have a pretty large ACO, and they will be reporting to the Medicare Shared Savings Program under the MIPS APM scoring. Can you talk a little bit about the differences between the reporting requirements of the MIPS APM versus the advanced APM?
Yeah, so it depends, as Jen mentioned, it depends on the track you fall under. So APMs that are considered MIPS excluded, so those are advanced APMs, are for this year Medicare Shared Savings Track 2 and 3 and Next Generation ACOs, as well as the Comprehensive Primary Care Plus model, the Oncology model, and the end-stage renal disease model. So you have to fall into one of those programs. You also have to be submitting at least 25% of your claims through that advanced APM, or see 20% of patients through that APM in order to be considered a qualified advanced APM participant and thus be excluded from MIPS. If you are in that category, which according to CMS very few practitioners will in fact be, you would continue just to report based on whatever ACO model you are in, or practice model you are in, on the quality measures they require, as well as have that certified EHR edition, and then, as I mentioned, take on that more than nominal risk. So those all vary depending on where you are. If you are in an APM that is not considered excluded from MIPS, so as Jen mentioned, the Medicare Shared Savings Track 1 or Pioneer ACOs, you would fall under MIPS, and you would still be required to report roughly the same as any other MIPS provider. However, you get what's considered like preferential scoring under the different categories. So it depends on a lot of factors. Some, I know a large ACO here in Massachusetts that has like 700 providers that will be their track 1. They are actually reporting all of their providers, which are MIPS APM providers, as individuals. They're not planning to report as a group based on the requirements there. So it really depends on where you fall and what the specific needs of the organization are and how they decide to report. I don't know, Jen, if you can speak to what's going on in Vermont. I'm not familiar with that one, how they're reporting. Are they doing a group?
I think right now they're considering applying as a group, and I think we've done a great job of explaining that what CMS is really intending to do is create a flexible program that has a place for everybody. And so it's difficult to answer generally about what everybody should do. And I just want to encourage the folks on the line to use the frequently asked questions where we can do research and answer your personalized questions or your practice's personalized questions, because it's very nuanced. Wouldn't you say that that's true, Leila?
Oh man, from one practice to another, one individual to another even, it can be a completely different situation, and it really depends on where your focus is. Some clinicians might want to work on patient engagement as their main focus area, or maybe population health. So as Jenn mentioned, it's flexible, it's nuanced, it really could go a million different ways. So any questions you have, because this is obviously as clear as mud, please reach out to us, because we're happy to help investigate those questions. We might not immediately have the answer, but we'll try to use our network. And we want to make sure everyone's successful and hopefully avoid the negative payment adjustment. At worst is budget neutral, and hopefully gets at least some sort of incentive payment along the way.
Thanks, Leila. It looks like there is a question in the chat box. I'm not sure if you've already answered it, from Jill. For reporting on MIPS quality measures, our practice is only reporting their Medicare patients or all patients.
So can you explain what you mean by all patients, like every payer, I'm assuming?
Jill, are you on the line? Would you like to clarify? You can press #6 to unmute yourself. Or you can clarify in chat.
Hello?
Hi, Jill. We can hear you.
Hi, yes. The question is, yes, just Medicare patients or for all payers when reporting.
So these will be, so it'll be based on the same methodology that QRS utilized. So it would be for all patients that fall into whatever bucket for those specific measures, depending on what you're reporting on. Again, it depends.
Okay, thank you.
Sure.
I have a question. I just wanted to find out, has CMS clarified how practices will be submitting their quality data for the 6 quality measures? Or are they still waiting to give that information?
Are you referring to what method they're reporting?
Exactly. Like how do practices actually report that data to
Yeah,
CMS?
so that's where they have flexibility. So depending on what measure you pick, or if you're a specialist and you pick a given measure set, you can report several different ways. So there's through a QCDR, through a registry, EHR Direct, or if it's through a group, you're using the G-Pro web interface. So it really, again, not to give you a very vague answer, but it depends on what measures and methods you decide to pick, or your practice that you're working with picks, because there's just a bunch of different options to make it as flexible as possible.
Will CMS be giving instructions to the
great way.
Sorry, could you repeat that question again?
I was just going to ask, will CMS be giving instructions to small practices? This wouldn't be for group practices. This would be for individual small practices. Will they be providing instructions on what to do, or how would the practices find out about the different reporting options?
Sure. So the small practices, so I'm assuming you're referring to probably less than 15 providers in a practice, can definitely reach out to us. Again, not knowing exactly what measures they're picking, it's hard to say, yes, just go right here and select. We're happy to work with them. If they're part of the QPPI initiative, they have individuals who can reach out to them as well. There is, if you go onto the QPP website that Jenn showed you the link to our website, or is right at the bottom of the slide that's currently showing, there's a nice document on their final page of resources that actually goes into the specifics of each measure and the numerator-denominator criteria, and some more information about that specific measure that might be helpful depending on, again, what they choose and which direction and all of those other elements.
Great, thank you.
I just want to follow up on that CMS is not reinventing their systems for submitting measures, and so you're asking about the kind of technical aspects of submitting, whether it be to EHR Direct or Registry or QCDR. all of that information right now can be accessed on the CMS.gov website, and there are detailed instructions. The kind of feedback that CMS has gotten about their old website is difficult to navigate, and so feel free to reach out to us so that we can point you to the exact location on the CMS website on how to upload that data. Also, I just wanted to put another plug in to that readiness assessment that you can access on our MACRA resources web page. A nice way to use that is to send it to your practices, ask them to complete it, and we'll have a lot of information there about what measures they are interested in submitting, what improvement activities they might be interested in working on. Many of you probably know if your practices have a test community use, but perhaps you don't. So you can gather all that information in one place and use it as a point of reference and a starting point.
And one more thing that Jenn mentioned about the readiness assessment, which is a great tool, and thank you for mentioning that again, for the improvement activities, that new category, those are attestation only. So basically, you say which measures or which activities you're planning on attesting to, and it's simply a yes, no. I did whatever, patient empanelment, yes, no. Having some experience with audits, having completed CMS audits and been on the receiving side of CMS audits, I've been stressing a lot to the practices and providers and different groups I've been working with. Document. Have the supporting documentation for that 90-day period, because again, all of those activities have to be completed for at least 90 days, ready to go in a nice secure folder or file or wherever you feel comfortable keeping it. But have it ready, because more than likely CMS will target these measures because they don't require a numerator denominator to show that they've been successful. So you might get some questions about, well, what did you do to increase access to appointments? Or what did you do with the QIO? Or how are you participating in TCPI? So just have whatever supporting documentation ready and available, because it might be very helpful down the road.
Thanks, Leila. Looks like we have one more question from Joan. Has CMS defined what they mean by participation in TCPI, and will it be more than just enrollment?
That's a very interesting question. No, they do not provide a whole lot of information on what exactly is required for all of those activities. At the moment, I would say enrollment is probably all that you need to have in order to satisfy that measure. Of course, performing additional activities with TCPI would be helpful, but at the moment they're not specifying how much engagement there needs to be.
Thanks. Again, we'll give a couple more seconds or a minute or so for anybody else to ask a question. #6 to unmute your phone line, or you can pose a question in the chat box. Before we wrap up, Leila or Jenn, is there anything else that you guys wanted to add?
Hi, this is Catherine from Rhode Island Quality Institute. Can you hear me okay?
Hi, Catherine. Yes, we can hear you.
I had a question back. I think Jill had asked it at the beginning of the question and answer section about the quality measures, and if it has to be just Medicare or all payers. So you said it was like PQRS. So PQRS is actually only Medicare patients, eligible Medicare patients that you're submitting measures on, but meaningful use was for all payers, their clinical quality measures. So can you clarify that for me?
The way I understand it would be all payers, and I can confirm that unless one of my colleagues has the answer right in front of them.
Okay. That was my understanding, but I think when you had answered the question, it sounded like it was only going to be Medicare with PQRS, so I was a little confused.
Yeah, sorry about that. Those measures are, they say that's the component of the program called PQRS, but they are looking to make it more, not broad, but, that they're pulling in all those patients. That's why it depends on how your provider bills and where they have the place of service, and it's all those elements that come into play.
Okay, but it would be for all payers, so
all payers. Based on my understanding, it's all payers. Sorry, my computer's deciding to not let me in at the moment.
Perfect. Thank you very much.
Thanks, Leila. A few more questions. for claims based on measures for quality, wouldn't this be only Medicare patients? That's from Anna.
So that's where it will depend on what method you report. Again, there's multiple different components.
Okay, great. It looks like Joan has a similar question. Will payment adjustments be made on Medicare-only payments?
Yes, those are the Medicare Part B. So the dollars, so in order to be eligible for the program, you have to submit at least $30,000 in Medicare Part B claims, and it takes into account any sort of incentive or penalty off of those Part B claims. Going forward, in at least the eligibility piece, they might include additional claims, but at the moment they're not going to.
Most payment adjustments don't impact the process for 2 years. So in 2017, January 1 is when they're starting MIPS, and the payment adjustments and incentives will not impact those Medicare Part C payments until 2019.
Thanks, Jen. So, Jen, do you have any other final kind of comments or anything you'd like to add before we wrap up?
I don't. Thank you all for participating. If you have additional questions, definitely reach out to us.
Thanks, Leila, and thanks, Jen, for a great discussion and presentation today. We really appreciate it. I just have a few last-minute announcements before we end the call today. When you close out of this webinar, an evaluation will automatically pop up on your computer. If you could please fill it out, we'd really appreciate it. If you don't have time to fill out the eval right now or you're currently sharing a computer with someone else, you'll receive an email tomorrow morning with a link to the eval, as well as a link to the event page on our website. The PowerPoint presentation was in your day of details email and will be posted on our website soon, and within the next few business days, a recording and a transcript of the webinar will also be added. Thanks again for attending. Thanks again to Leila and Jen, and I hope everyone has a great day. Thank you.
Thank you.
The user has disconnected. The conference will be terminated in 5 minutes.